to have you guys here. And, you know, I already knew Mark's work long ago, but Dr. G, I was basically looking over your work, and you've got some great resources too. So I think we can have a really unique discussion. We know sleep issues have been a problem for people for eons right now, but now I feel like the sleep issues are on steroids. And even someone like me who prioritizes sleep quite a bit, I've had my own share of sleep struggles through this time. So I thought for this particular presentation, you know, it's not a presentation, it's just a discussion, and I'm definitely not going to pretend to be a podcast host. I've been asked to host podcasts, and that's the last thing I ever want to do. So it'll be more discussion amongst colleagues. Yeah. But I thought we would start off the topic and just, you know, give like each of us give a one-line intro about why they're passionate about sleep and how they got into sort of this field. So Dr. B, I'm going to start with you, put you on the spot.
Yeah, I mean, you've heard this story before, Ron, and if you read my book, which I think you did, it's the first chapter. I had sleep apnea, and unbeknownst to me, and I was told one day by my 3 daughters that, Dad, you sound like a freight train at night. And the irony is, the funny thing is that it was really my wife. I was snoring. She had severe sleep apnea. I had mild sleep apnea. This was in our late 40s, a world completely not known to us at all. She's in biotech and was a cardiac care nurse. And I mean, we had no idea. So it was really a personal story. And by solving and going through the system and learning of all its inadequacies and how difficult it was, even as healthcare providers ourselves, I learned a lot about it. And then that frustration led to my venting to a lot of people. And then one of them was my daughter, and she just said, Dad, let's write a book and solve this. And of course, the connection between dentistry and sleep apnea is phenomenal. And just in one sentence, dentists can recognize sleep apnea decades before a physician can. So for me, that was a game changer. And that's why I really started treating. Unfortunately, we cannot diagnose sleep apnea. But screening for sleep apnea, every patient, as time went on, got a screening for sleep apnea, even if it was a 1-year-old. So that's my story. I feel better now, but I didn't know that until in hindsight, that if I had not fixed my sleep apnea, I wouldn't be here today. I'd be a wreck. I mean, and that's just mild sleep apnea. So personal experience brought me to this whole world of sleep. And now, thank goodness, it's on fire, and dentistry and physicians are better, collaborative, and that's important. And I'm sure we'll talk more about that today.
Absolutely. Thanks so much. Dr. G.
Yeah, my first exposure was probably when I was teaching at UMDNJ in Newark. I didn't really want anything to do with sleep apnea, or kids. And then when I went to NYU and I started running the program there, I got John Parker came in. He's a big sleep dentist from Minneapolis, and Wayne Hallstrom from Vancouver. And after listening to them, something just, the light bulb, clicked, everything went on. And I realized that dentistry, we were perfectly poised. And then that was in 1990. And then I guess around 2012, I heard Karen Bonnick, and she started talking about kids. And I realized, like what you were saying, Mark, I realized, first of all, that I'm a mouth breather. My mother was a myofunctional therapist. My dad treated TMJ. We were really serendipitously, we've been opening the airway by bringing the jaw down and forward for 40 years. Never realized really what we were doing. And then we had this thing, the cone beam CBCT. We could visualize the airway with imaging. And then we had this home sleep testing came about. So there's a lot of good things that have come into the field of dentistry over the last 10 to 15 years, which have made a world of difference. And then I realized, how we could transform lives. It was so much more profound working with sleep than it was even, and TMJ was great, don't get me wrong. Mark, getting rid of headaches, giving people lives back, getting rid of pain, that's fantastic, right?
Right.
But sleep trumps that. Sleep's the top in dentistry. So I think, I don't know if you would agree, but a lot of us say that, airway and sleep trumps everything else in dentistry.
I do agree.
And, that's it.
And also in dentistry, we are responsible for and most aware of, especially in our training, of one of the major root causes of sleep apnea, that is facial development. I mean, physicians don't get that training, and it's been sitting literally under our noses all all this time?
So that was a very big revelation for me as I've been exposed to your work. And so my background, I'm a physician, so I'm an MD here surrounded by dentists. And I work for a large multi-specialty group. And so I had a very sort of a regimented approach to addressing sleep and sleep apnea type issues. It's very protocol driven. I've only got a limited number of specialists that I work with. But I found that sometimes the results and the outcomes were pretty suboptimal in many of my patients. And my background is really, I treat diabetes and I work on preventing heart disease. And one of my big approaches is I want to catch diabetes and heart disease way, way before the glucose goes up. So I talk about catching pre-diabetes. And that's what I love about both of your work is because you are catching this at the earliest stages where we can minimize the amounts of invasive procedures we have to go through. But then I also want to expand upon what you guys have said because not only are you guys experts in airway and sleep, you guys are both experts in just general sleep because it's not like you're going to close your ears when somebody asks you about melatonin or insomnia or waking up at 3 in the morning. So today's discussion, I think we all want to elevate the discussion and enlighten our patients and our listeners about the breathing issues, but also you guys have a very unique perspective on general sleep type issues too. And I want to jump into that actually right away. So we're basically recording this during the COVID-19 pandemic. And I just wanted to talk to you each and ask you, there's probably some unique things that you're seeing around sleep during this time, and then maybe some of the more garden variety issues, which are just becoming much more common. So I'm going to start with you this time, Dr. G. Maybe can you highlight some of the unique types of things that you're hearing during this time?
Yeah, so insomnia seems to be really disturbed sleep, fragmented sleep, insomnia with the stress of what's going on. The guys today that I was with playing golf, no one is sleeping. Everyone's worried. Either they're worried about the economy. Like I'm not really stressed at all about getting the virus. Maybe I should be, but I'm really economically and having to bring back my employees. And am I going to have another downturn? Is Cuomo going to shut us down again once we reopen? We're not even officially reopened yet. And you listen to everyone on TV, this could last, 12 to 18 months. So people are not sleeping well. So we're looking for aids and we're looking for what can people do for insomnia. This is just the whole field, behavioral sleep, not even talking about the airway and sleep apnea. So that's really, and the second one that's kind of interesting, I'm treating so many earaches. I'm treating so many men that are having, my brother-in-law, but I can think of 3 or 4 guys, they're coming in with jaw pain and headaches and ear pain because of the increased clenching during COVID.
Oh, wow. That's interesting. Wow. So this is new onset TMJ type jaw type issues in individuals that didn't have it before. Yeah.
New onset. It's usually women. These are men who are being stressed out by, it's a once in a lifetime thing. It's right. It's the worst stress that some of us have faced. And these guys are presenting with this intermittent dull ear pain and jaw pain.
Wow. Interesting. Dr. B.
Yeah, I don't think you can really underestimate the amount of stress during this crisis. We're all feeling it to different degrees. I think one, we hear the horror stories of dying or not being able to breathe, and then the stress of not being there for your loved ones if that does happen. And then, of course, the economic impact or ramifications. I mean, this will have multi-generational effects with families and small businesses, especially, and many dentists, typically most dentists are small businesses. So it's huge. And this is what I'm seeing, certainly insomnia, but people staying home, stressed, not sleeping well, and then how well you sleep impacts how you respond to insulin. And then because you're tired, the next day you wake up and you're making bad food choices that will, affect your resting glucose levels. And I mean, it's just this multifactorial spinning hamster cage wheel that has sped up essentially. And so all these metabolic things are happening. And then as we gain weight, there's the COVID-10 or 15, however you want to call it. Then our airways are impacted. Our tongue gets bigger. Our airway is more likely to collapse because it's bigger. We can gain fat in the airway and the tongue. And then the stress, the cortisol levels are off at night. So all these things are actually affecting our sleep, which in turn makes it worse for us the next day when we open the refrigerator door, and which again then impacts our sleep. So this is, I mean, I remember 9/11. Michael, you were there again, ground zero. That was a lot of stress. I was worried for my family. I remember literally having a patient at 7 a.m. and at 7:15, we both looked at each other, all three of us, the chairside, and said, we're going home, because it was all just unfolding on TV. And I'd have to say that was a stressful moment for me. I was a Cold War child. I was always, you know, like, where's the closest bomb shelter? That's how I grew up in San Francisco. I think that kind of brought a lot of that back. So, but COVID, it's huge. I think by staying home, by not being able to see friends and family, not being able to practice, which a lot of us thrive on and love doing, like Michael was saying. I mean, we really feel good when we come home and have improved someone's life, more than just filling a filling, but made them happy and made them thinner and you know, healthier and all that. So by treating their sleep. So yeah, COVID has been a game changer. And I see this in my patients in so many different areas: blood pressure, stress, their eyes, their hair. I mean, it's very sad to see.
Yeah, you know, when I give talks on stress, you guys highlighted the key issues. Well, I always use an analogy like this is kind of like being chased by a tiger looking at your phone. But now we don't need analogies. This is actually scarier than being chased by a tiger. At least you know you're being chased by a tiger. But now we're facing our mortality and a fear of the unknown, because every day is a different day. Totally agree with that. And Mark, I wanted to highlight the point that you're right, the biometrics, I'm seeing blood pressure, glucose out of control. And the worst thing is our patients are not connected to their healthcare system. And not only are they not connected, even when we open back up, I've been doing a lot of televideo visits, patients are scared as hell to even come into a lab. They're not going to be coming in. So their numbers are going to keep getting worse. The metabolics are going to keep getting worse too. So I think at some point we really need to comfort our patients and not have them be so influenced by the media. Obviously, we want to practice the precautions that we're talking about. But as you know from the New York data and international data, the three independent factors that really increase severity the most are diabetes, obesity, and hypertension. So we got to be laser focused on that rather than, you know, how long should I be wearing this mask and just obsessing over hygiene. We got to do all the basics, but I think it's time for us to really take control there. Another key point you brought about 9/11 is at least during 9/11, we still had outlets, right? You can socially connect, you can go work out. Now we're faced with the stress, and we have very limited outlets right now because we're sheltered in at home. So it is really an imperfect storm. So have you guys figured out any sort of unique ways to support your family and your patients to really mitigate the stress? Because you're right, the stress is at toxic doses right now. But any unique approaches that you guys have helped people through, friends, colleagues, patients as well?
I think teledentistry is a big thing. I mean, it really does work. I mean, our patients rely on us, and, you know, being in front of each other is one thing, but just hearing each other's voices and reassurance from us, you know, for example, what Michael was saying, what is that pain here? You know, is that toothache? Is it just tooth sensitivity? Or is it really a cavity? And, you know, what should I do because I can't come see you? What should I be doing at home in terms of home care and diet? So I think teledentistry, I keep telling other dentists, now's the time, if you haven't already, have that avenue in your practice. It should be built into your scheduler, your software, where you can be at home helping your patients, and you can bill for this. I mean, this is, of course, the COVID thing has made it easier because a lot of the regulations have been temporarily dropped. Hopefully, I hope that's a continuing trend. It's important.
Agree.
Yeah, I mean, it's a good question. I think we've been reaching out to our patients and telling them that this really.
Oh, I think we just got.
Did we lose Michael?
House to exercise.
Hey, Michael, you cut out a little bit, so I'm going to have you restart from what we've been telling patients. You just cut out during the punch. Yep.
Okay. Yeah. Everything was freezing. So I think what we're telling our patients to do, this is the time to stockpile your reserves, to build up your immunity, to get outside, vitamin D, get outside in sunlight for at least an hour a day, talking about getting at least 3,000 steps in, if not more, you know, nutritional things to do, vitamin C, zinc, and things like that. and, you know, to work on diet. So now's the time maybe to think about, this is the time to go back and reassess. Life is going to be different after COVID, right? Some things we're going to change. Hopefully things will change for the better for some things. And so teledentistry, telemedicine is one of them, that this may be here to stay. I always say, I like to palpate. I like to have my patients there. I like to look at the imaging. So I'm old school. I get something out of being there with the patient and laying on the hands, but you know, you can't always do that. So we've been really limited in what we've been doing with tele. You know, I talk to people around the country, but I think that that's a great idea. But again, it's a good time to stockpile for yourself, to build up your reserves now. Yep. And this could be a long siege. So this could be that's the difficult part of this. We're only 2 months in. Most people are burning out now. Most people can't really take any more. This is what worries me. We've been into this for 2 months, and it seems like it's been 6 months. If you're going to tell me, or if you were to tell me that this is really going to last until we get a vaccine or herd immunity, that this could last 12 to 18 months, kind of this attitude, if you will, this fear, I just don't know how it's like, it's enough. Most people are saying, I've got to get back. I want to get back to work. You see the protest. No one really has the answer. Do you go back to school? Yeah, we're going to go. Notre Dame, yeah, we're coming back. Cal State, no, we're closing we're going to do all, by tele. So, I mean, there's such confusion, and we don't know really what's going to happen until we start opening up. So there's a lot of unknowns.
I think I agree. There is a silver lining. I mean, the silver lining is that first of all, we can't go to restaurants. And let's face it, when we go to a restaurant, we're eating beyond our normal caloric intake. We're eating richer food. We're maybe eating some industrial seed oils. So that's gone. Also, it's hard to get food now. We don't shop as often. We're not likely just to get in the car if we have a hankering for some ice cream or something, because it's something we've been told not to do. So now is the time to really look at your diet and your habits, whether it's home care for oral hygiene, or, how much food do you eat? How much food do you put on the table? How closely to bedtime do you eat or drink alcohol? And so, of course, there's lots of other silver linings in there. We're connecting more with people, even though it may be a Zoom call. But I think what I'm telling my patients is now's the time to work on that, but also on sleep. And I know personally, I've been going to bed about an hour earlier because of this COVID thing. And it's, I think it's been helping. And we know that sleep affects a lot of the things that in turn are comorbidities that are bad to have if you are exposed or you get enough of a titer of this virus. And then, it dooms, some people are doomed because of that. And I know Ron has nicely on his website, has spoken to this, Covicity and all that, but there are things that we have to face in our lives. If we're overweight, if we have a little roll around our belly, I mean, these are all things that predispose us to infections like this, especially novel ones.
Yeah, absolutely. I think building up the internal reserves, I think, is a great point. And you brought up, what I love is you brought up getting outdoors, sunlight, and vitamin D, because I'm having a lot of patients ask me, should I double up on my supplement dosage? They want the magic pill, basically, to help them through this. But as we all know, after doing this for many years, there's really no magic pill out there. It's just the basics that we talked about. Vitamin D in particular is a really interesting one. I wanted to talk about that for a second, get your perspective. But I already have patients that are significantly vitamin D deficient. And now what's happening is they were already sort of sheltered in during the winter because a lot of them are techies that don't get out much. And usually they sort of resurface Jan Feb, but now they're still indoors. So when they are getting tested, they have single-digit vitamin D levels. So I'm pretty concerned about that. So I try to get them to get out and get the adequate sun dosage. And then if they need supplementation as well, too. But I want to get both your perspectives, too, if there's anything unique about vitamin D and sleep, or even the airway and dentistry issues that you've been talking about. So Dr. B, I'm going to start with you this time.
So vitamin D is very important. Whenever I hear vitamin D, I always think of K2 and A. You got to have all three on board. It's a triad. And Dennis talked a lot about that triad when it comes to remineralization and teeth and bone density and development of the face and all that. But, and that has a lot to do with the airway, but the getting out in the sun is also very important for the circadian rhythm. And that's another thing I've been telling patients is that before noon, and this is something we didn't have the opportunity to do when we were getting up before it got dark, commuting to work, being at work all day long, being under blue lights, and then coming back during the winter and coming home to a dark, you know, artificially lit house, but really never seeing the sunlight. And that in itself affects sleep, because that circadian rhythm, you know, the adenosine drive, the sleep drive, and melatonin, all those hormonal factors that control our sleep, not control our sleep, but set it up properly and time it well, those don't really do very well. They don't reset and they don't start at the right time if we don't see that sunlight. So that advice that Michael's giving is key. That 1 hour of good trunk exposure of sunlight, morning better because you're not going to get fried midday. Also, it's probably better to do it earlier and further away from your sleep time, your bedtime. So that's important. D3, I mean, D3 and COVID are being discussed a lot together. It seems that people that are low in D3 are more susceptible to the bug, although the CDC just came out with something saying that it's not. But I think overall it is. D3 is very important. Get your blood levels measured, especially in the winter. You have to take more D3 during the winter, obviously, than you do in the summer. But, and you can take, here's one last thing. You can take too much D3. You can have too much D3 in your system, which can affect your sleep. So, and I've had that problem. I actually was taking 50,000 IUs for a time, and I was tossing and turning a lot, and I dropped it down to about 5,000 IUs, did the sunlight thing, and that helped. So there is too much of a good thing, but D is crucial right now, more so. Well, it's always important, but now it's very important to know what your serum levels are of vitamin D. It's a hormone.
Yeah, agreed.
And I would say, just to add a little bit, I don't know if you know Stasha Gomanak, but her big thing, she's a neurologist, and her program for sleep is built around vitamin D and B complex.
Right.
And that's a good thing to refer to look at for both professionals and for the public.
She's down in Texas, and she's great. You're right. She was in the Bay Area, Ron. I don't know if you knew, but she worked at Palo Alto Medical Clinic for a while.
Yep, yeah. Absolutely.
Yeah.
Great.
And then the other thing, with pain in New York, because of the way this hit, in February and March, most every patient is low vitamin. If they're not supplementing, they're low. At our latitude, where we are and most people are low in vitamin D. It's like across the board. And then the physician, I don't know what you would say, Ron and Mark, but between 40 and 60, what are you looking at as optimal levels? Because they're coming in at 25, some are in single digits. You know, is it between 40 and 60, or do you look for a different number?
Good question. So in my practice, looking at all the data, there are some people think that the higher the better. Some people say above 80, get to 100. But looking at a lot of this data, I think about 40 to 50 is about the sweet spot for most of my patients. And just to highlight one other thing is a lot of people have kind of used the vitamin D, as much as I'm a big believer in vitamin D, they kind of use that to explain the high incidence of severity in certain ethnic groups like African Americans, because they tend to have very low vitamin Ds. And although I think that's playing a role, I do want to say that I think it's playing a minor role, because we know African Americans and South Asians and others, they have a very high incidence of hypertension, obesity, and diabetes. So we want to keep our eye on the ball, because a lot of my patients who are high risk, they feel like if I take my vitamin D tablet, I don't have to worry about the diabetes and just everything else will fall in place. But it's part of more of a cohesive, comprehensive strategy. And then the other risk too is if you over-supplement because you're looking at the news and you're like, I got to triple my dose, there is a risk of that calcification, if you're not doing it properly, ending up in your coronary arteries. And the last thing we want to do is elevate your cardiovascular risk, which is going to increase your COVID severity risk as well, too.
Yeah, I think people that are taking a lot of calcium and a lot of D3, and they're not taking K2, I'm just worried that calcium in your blood is just not getting to where it should be going, and that is teeth and bones and calcified tissues. And you can even calcify your hypothalamus, I think. Or no, the pineal gland. The pineal gland can calcify if you have too much calcium. And then I think also it's pretty clear to me as a dentist, I have a lot of patients that take a lot of calcium, They have a terrible diet. They're not getting any K2 from diet or as a supplement. And they're getting a lot of tartar. I mean, blood and saliva are essentially the same thing, minus the red blood cells. And you've got a lot of calcium in saliva. It's there for a purpose to help recalcify teeth, remineralize teeth, but you can have too much. And then if you're a mouth breather and your mouth is continually dry, you're going to get a lot more buildup of tartar, which can eventually lead to gum disease if it's not removed.
Yeah, even mainstream doctors have taken our foot off the gas pedal for recommending calcium supplementation. Most studies show that it really doesn't do a whole lot for bone health. Again, just talking about lifestyle, get outside there and walk and do some weight training, do some bodyweight exercises, and get vitamin D naturally and supplement if needed. But really, there's really not much purpose for getting calcium through supplements for most patients. And most studies show that for osteoporosis prevention, it doesn't do a whole lot. So totally agree with more of a natural approach to that for sure. Yeah. The other thing I wanted to bring up too is I'm finding my patients are staying up a lot later. You brought this up, Dr. B, as well. People are just exposed to so much media. And I had to actually go through a detox process because I had my Apple News. I've got a couple of WhatsApp chains. I've got old high school and college buddies sending me all types of COVID-19 jokes. I mean, I was getting so many streams of information, in addition to my medical group sending me about 50 email updates per day. But, I've had to actually implement some media detox strategies. I call it media distancing. Is that something you guys have been successful at doing or getting, your patients to sort of adhere to that too? Because like you said, it can destroy our melatonin, our melatonin and cycle in the evenings.
I think what's happening is that the Netflix, you get into some of these Netflix shows and then it automatically goes to the next episode. And you're up till 11 midnight, where I normally would be asleep by 9:30, 10, as an escape from the stress, Yep. And I think that's great to escape the stress. But I think Mark's right. We're staying up. I try to get more sleep, and my patients say, this is the time where I actually can get more sleep. But I think we got to be mindful of not staying up and binging, until 1 a.m.
Well, and listening to the news as well. I just have a rule. I just stop. I try not to look at a video version of the news. I listen to it or read it, and then by noon or 1 o'clock, that's done. I just don't look at it again. I don't want to see anything stressful before I go to bed, because I think it does contribute to, when you wake up, that's maybe the first thing that pops in your mind, and then it's hard to get back to sleep. But the blue light of, staying up late and watching the next Netflix show and the next episode, and that's tough. That is, it makes you feel good, but it can be very dangerous. That blue light just basically rewires your brain for the rest of the night. And so I've gotten to the point now where I have abused my sleep so long and so much that for the last 10 years, I've been paranoid, and I'm trying to catch up if that's possible. Some say it's not. I'm just thinking of all the methylation and the damage I've done to my body from being up till 2 and then getting up at 5 or 6 the next morning, and being able to do that, burning the candle at both ends. So I'm at the point now where I don't get rigid about many things, but my family can tell you, my ring tells me when to go to sleep. I'm in bed. I set an alarm to go to sleep, not to wake up. I'm a little obsessed about sleep, and it's worked. I mean, it really has changed my life. It's made me crave carbs less. I gave up sugar 10 years ago. It was much easier doing that after being able to sleep through the night. And then if there's a night where if I get up in the middle of the night and go to the bathroom, to me, that is a catastrophe. That is a failure. I must have had some apneas that allowed that whole event to occur. So, and thank goodness that's very, very rare. But so, yeah, I mean, there's so much temptation out there, especially now, because we have more time at home. The refrigerator's there, the TV's there. It's tough.
But I think you're right. Go ahead. I'm sorry, Ron.
No, it's okay. And I was just going to say, a lot of people get fixated on the concept of sleep duration. So I've got a lot of techies that go to bed at 1 and they get up 9 or 10. They don't have to commute to work, and they brag to me that they're getting 8 hours of sleep. So I kind of wanted to talk about just phasing in bedtime too. So from my perspective, it's really key that we get that first half of the night down, because we know in that first half of the night, we're getting more of that deep phase sleep. We're releasing more growth hormone. Glucose metabolism happens really well. So I tell people 8 hours of sleep, like 10 to 6, is very different than 1 to 9 a.m. And I was just kind of curious, and I'm going to let you finish what you were saying, Dr. G. I was curious if there's anything from an airway perspective, too, in terms of me getting 8 hours, it's 10 to 6 versus 1 to 9. But I'm going to let you finish up your comment first, Dr. G, and then maybe we can talk about that.
No. It's kind of gone right now. So, but I can comment about the airway. I mean, I know and I wanted to talk some more later on about sleep testing, because I think this is the time to encourage our patients to get tested. And, but I can talk about that in a bit. But for me, the REM sleep occurs later in the night. The REM sleep very often is when the muscles are paralyzed. We get more apneic events in REM sleep. And so for me, I've even looked at people that talk about biphasic sleep, get 4 hours, get up if you have to read a little bit, and then get your other 4 hours. So I don't know. I'm interested to hear your guys' thoughts about, is it 10 to 6 is different than 1 to 9? That's an interesting conversation. I hadn't really thought about it too much, so I'd like to hear what you guys have to say.
Well, I'll tell you from a glucose. Oh, sorry, you go ahead first, Dr.
Oh, sorry. No problem. I focus more on the circadian rhythm, and because I think if you follow that to the minute, in other words, I try and go to bed every night. I start running upstairs around 9:30, and my bedtime is 10:05. Depends on sleep latency and all that. But then I wake up without an alarm, and it's amazing how I don't even have to look at the clock. If I slept well, my body has told me how long I have to sleep. I wake up within minutes of the same time every morning if I stick to that circadian rhythm. So my thinking is that by doing that and optimizing where I sleep and having the airway open, I wear an oral appliance. I test, I monitor with the Oura Ring. Everything's data driven. So I'm not worried about how long I sleep, and my numbers tend to be very good unless I lose an hour of sleep. If I go to bed an hour later, that will disrupt that will make the data not look as good. So for me, it's all about the circadian rhythm. Follow that to the minute, and everything else should fall in place as long as you're able to sleep, as long as your airway is not collapsing. But to me, that's what drives how long I should sleep for. I let my body decide, but I have to follow the rules, and that is go to sleep at exactly the same time.
One more thing. Ron, I just want to say, so we've told the patients not to eat after 7 p.m. So if I follow that rule, then I would go to sleep around 10. And I like your concept, totally agree with the circadian rhythm. From a glucose perspective, we don't want them eating, we don't want them drinking too late. We don't want no caffeine after either noon or 2 p.m. And we'd want no eating past a certain time so that it doesn't interfere with our sleep. So from that perspective, and I can see then how it would affect insulin resistance and glucose, right? And I've even talked about intermittent fasting a little bit with my patients. So no, totally agree.
Yeah, and my patients at work continuous glucose monitors until they see that number in the morning improve from their earlier bedtime. They don't believe it. And it's funny because a lot of people think that they're programmed to be late nighters, but a lot of my techie friends, when we go camping, everybody gets sleep at 10 p.m. Right? We put them back in nature. They realize that this is really the natural rhythm. But I definitely want to transition into a little bit about breathing, because I think it's so overlooked until my clinics. People have overt snoring and daytime sleepiness where they're falling asleep at the wheel. So I want to make sure I have a chance to address that. Early symptoms that we should look out for, and also what is a good way while we're to maybe simply test for some of these things. So, Dr. B, you want to start and move on?
Yeah, I mean, and as Michael said, testing is very important. And the question is the testing catching all cases of sleep disorder breathing? And I'll answer that question. I'm sure Michael has a response to that as well. But essentially, sleep is a very complicated thing. It's very broad, and there are many different types of sleep disorders. And your airway doesn't have to collapse. You don't have to have low SpO2, oxygen saturation in your blood to have sleep apnea. You can be interrupted many different ways. Blood glucose levels, the dawn effect. It can be the dog that's sleeping with you. It can be your sleep partner who's snoring. it's very, very complicated. So testing is really, really important. And I'm not 100% happy with the testing. Most of these apps don't work. And then there's resistance to testing, and there's a lot of denial, especially with my male patients. I mean, even though they are shown a recording of themselves snoring, and I guess I was in that boat as well, it's just so difficult to, and it's such a insidious, gradual kind of disease or condition that you think it's more just old age, that you're not sleeping well, that you're getting up in the middle of the night to go to the bathroom, that you're kind of creaking a little bit in the morning, and you're tired during the day and you have to take a nap. And I took all of those things for granted and as being normal. So I think when most people think of sleep apnea, they think of breathing, and we should probably start talking about that. But the airway is impacted by so many things. And again, dentistry is in the hot seat here, or in the pole position, because a lot of it has to do with how we develop, how our face develops. I always try and simplify this, because if you're not a dentist, it's complicated. And Michael, correct me if you think this is too simple, but there are 3 boxes that have to develop. There's the mouth box, there's the airway box, and there's the nose box. And when we're kids, and we come out of the womb, and hopefully we've picked up a lot of mom's vaginal microbiome, and that's all in place, because that has a lot to do with gum disease later. But being pushed through the canal, and then breastfeeding, and that sucking motion, and not having a tongue tie, hopefully that's a midline defect. All these things have to work really, really well so that we develop these boxes. If the mouth box isn't wide enough, then the ceiling of that, which is the floor of the sinus, doesn't get wide enough. And then also the airway isn't affected, because we don't get that forward downward growth. So these boxes, which all contribute to the patency of getting air in and expelling air, and if they don't grow to their full potential, then you're guaranteed to have sleep apnea. So how do we test for that? Michael mentioned the CBT, the cone beams. They're controversial. I think they're great. It gives you some baseline, even though the patient's not asleep when that image is being taken, and they're upright. But I think it's all about testing, and we have to understand how wide of an umbrella we have to throw, to cover all these sleep problems. And then we need better testing, and it has to be more available. It has to be cheaper, and insurance companies have to pay for it. And Ron, I have to say one more thing. Yeah. Not to you, but to your profession in general. And again, medicine and dentistry separated a long time ago, which has been very deleterious to our patients in general back in, I think it was 1840. That every time, at least 10 years ago, it's less so now, but in the beginning, when I referred a patient for a sleep study, the physician would, the general physician, the primary care physician would push back. They would say, no, there's no need. And, I was sending patients who are thin and healthy, but because dentists can see the oncoming sleep apnea, we can literally see UARS. We see it. When Michael goes to a cocktail party in New York, he can see UARS.
Right.
Right. Anyway, I'll give it over to Michael now. I've said enough, but it's
and Michael, when you respond to this too, I just want to ask you, what % of general dentists are looking for this? I mean, are most dentists looking for this, or do you have to have some sort of special training for this? So maybe you can address that.
I think it's important to realize that only 20% of these patients at most have been diagnosed. And then unfortunately in the United States, a lot of those have been put on CPAP, and patients, of course, maybe 70% are non-compliant. So we're seeing that in Europe, it's much more equal with oral devices and CPAP. And in terms of mean disease alleviation, we know that oral devices work fairly well because they're more comfortable and the compliance rate is higher, even though efficacy may be 80%. So when we look at those people in the United States, we're up to maybe 80 million. Atul Mehrotra is down in San Diego. He's done some great work. It was written up in Chest. So the rates where we used to quote 2% and 4%, we're up to 37% of the population. So wow. as obesity increases, as diabetes increases, so And this brings us back to that inflammation and everything is related to everything else, like you guys have been saying. But if you look at the sheer numbers and you look at our failure to diagnose in this country, and I always say men are in denial. There's a river in Egypt. Men are in denial and women speak in code. And men are from Mars, women. So a woman's never going to say, I'm fine, I'm okay. But the number one question that I ask is, if I say, are you tired? No, I'm not tired. I'm not, who's tired? I'm not tired. I say, could you be more refreshed? A totally different question. And everyone says to me, that's the number one complaint in New York City. Doc, I'd like to be more refreshed. I'd like to feel like I felt when I was a kid. And I'm getting these executives coming in and I'm getting thin women with big tongues. And that UARS, that upper airway resistance. And I totally agree with the 3 boxes. Totally agree with that. You know, we wrote a book called Gasp with Howie Hindon. And I love going back to kids because we can see it. Kevin Boyd. So Ron, most Homo sapiens have this problem because our faces have gotten narrowed. Our faces, I have a long face from being a mouth breather. Our snouts have gotten pushed in. So we have flatter nasomaxillary complexes. Everything's been pushed back. We don't have the snout of a Neanderthal man. We don't have the face of a paleo man. We have the face of an industrialized Homo sapien. And Homo sapien is almost contiguous with sleep apnea. And if not sleep apnea, upper airway resistance. So one of the things that we look at when we look at testing, we don't always see it. And often we don't see it with oximetry. We don't see it with O2 desats because we're not getting in these cases, it's not apnea anymore. And it's not hypopnea, it's upper airway resistance syndrome, which results in fragmented or disturbed sleep. And we're getting a lot of fragmented and disturbed sleep. And that's what portends and predicts Alzheimer's, dementia, and cognitive impairment. It's that lack of slow wave sleep. And something that's not really talked about very often is that decrease in slow wave sleep. So I'm afraid that that's some of the stuff that we're seeing now. But they came up with WatchPat 1, which is a disposable test. So with COVID, it's great. You know, you mail it to the patient, it comes in through the iCloud. It doesn't have to be mailed back. And that'll give you an idea of the RDI. That'll give you some idea of sleep disturbance. It'll measure apnea and measure hypopnea. But yesterday, a guy woke up 18 to 19 times during the night. Mark's upset if he has to go to the bathroom once. This guy's brain was waking up 18 to 19 times, and I could show him on the graph. It was very clear that even though he didn't fully consciously wake up, his brain was coming right to the verge of wakefulness 18 to 19 times. And this guy's exhausted and no one knows why, and everyone's in denial. So I think it's time for people to recognize, and I was going to say to you guys, we know that the comorbidities, we know that morbidity and mortality of COVID is directly related to what you said, obesity, diabetes, these other comorbidities. So isn't this the time that we should really be addressing? Is this what's going to motivate people to try to get rid of their diabetes now and get rid of their obesity now so they're not as susceptible to dying or getting really sick from this virus? I mean, I just put that out there. Now is the time then to get tested.
The threshold for testing, the conventional test, the PSG, it's really set too high for you to get a positive. And Michael's right. I mean, and the classic example of this is a study out of Sweden where they took women that were very thin, very active, very healthy, very fit, no diagnosis of sleep apnea or anything, no complaint of any sleep issues. And when they were tested, I think it was just shy of 50% had some form of sleep disorder breathing. So, I mean, how doesn't that get picked up? Well, the PSG doesn't pick up UARS necessarily. The home studies, which are great, some of them, the patch is great, the watch patch, but home studies underreport. So that one guy that Michael was talking about, it's probably worse than what the home study indicated. And
exactly.
So again, we need to test more. I think, and I wrote this in my book, I think everyone should get a sleep study, and every 5 years. And there are some countries that do that. Iceland and Italy tries to do it. It's an important test to have. You cannot, sleep is not guaranteed. it's innate, but it's not guaranteed that you're sleeping well. And especially because we're not developing properly. Our faces don't allow us to breathe properly.
Yeah, you know, one key thing I want to bring up too is in the medical system, we were trained that sleep apnea is more of an obstructive disease, so we automatically link it to obesity or morbid obesity. But both of you basically brought up the point that it's really more of an inflammatory condition. And I know in my practice, a lot of people with normal to lower body mass index individuals have sleep apnea. And I'm assuming that's the same case that you're seeing. I think, Dr. G, you mentioned you've got skinny, high-stress execs that are having it. So I think one thing we have to highlight to doctors and patients is, yeah, weight plays a role, but it's really more inflammation. If you've already got signs of inflammation from your symptoms, from your blood glucose, your blood pressure, or even if those are all fine, you know, like you said, I mean, there's not much downside to doing a test that is relatively non-invasive. You're not getting exposed to radiation. I think I agree that most patients should fight for getting this test done at a baseline, because aside from chronic disease, it's about mood, it's about well-being, it's about productivity, it's about energy, and those things you just can't put a price tag on, right? So, yeah, absolutely.
Yeah, I think, Michael, you'll agree that your most frequent patient for sleep apnea is a thin, very successful, very hyper female.
Yes.
It's not the big neck. It's not the big neck, the big guy that's snoring away. I mean,
it's a narrowed nose. They might have had a rhinoplasty. They have a little deviated septum. I have enlarged turbinate. They've got a big tongue. They've got a narrow palate, very thin. They work out all the time and they're exhausted.
Yep.
So these are my failures for 20 years going back with my TMJ. These are the women that come back. They've got functional somatic syndromes like Avram Gold wrote about and like Guilleminault writes about. They have irritable bowel. Their nervous system is sensitized. They have low blood pressure. They get faint sometimes when they stand up. And their nervous system is sensitized because they've resisted breathing. And these patients are missed, and these are the ones that keep coming back. They've got tension headaches. They say they have migraine headaches. They clench every night. They can't stop clenching. They bite through their bite guards, and they do not have sleep apnea.
I've seen the orthostatic hypotension a lot in these young women that have sleep apnea. It's very interesting that you mentioned that.
Really?
Yep.
Oh, yes.
Wow. Yep.
Yes, and they have cold hands and cold feet.
Yes, Raynaud's. Yep.
My gosh, yeah. You know, I did want to ask you one thing is because I know despite us having this discussion, some patients are just not going to maybe get the type of testing they need. And everybody's about sort of home monitoring, apps, tools, devices. What's the best of the worst? Like if somebody really wants to find out an easy sort of screen that they can do now that they're sheltered in, do you guys have some recommendations, Dr. B, Dr. G?
Yeah, I mean, my recommendation is typically stay away from most of these fit trackers and things that are data that you're getting back that's based on moving. My favorite apps are, the simple one would be a night recorder, something that just records you all night long, and you can just play back only the sounds that the recorder recorded, in other words, snoring. That's very enlightening. And the other one is the Oura Ring. I don't have any affiliation with them. I just like seeing, and it's not 100% accurate, but it's pretty close. But to be able to see, you know, that you did get your, you know, delta wave deep stage well before the REM set in, and how much did you get? What time did you get up in the middle of the night? It shows you that. And then it tells you how long you slept, and then it gives you a score. So that's a great place to start. But as soon as COVID's over, if you think you have sleep apnea, I always recommend the PSG. Start with that. If you score well on that, and you're still tired, then keep going. It doesn't mean, a lot of my patients will say, oh, I passed, but they're still tired and they still don't sleep well. They have fragmented sleep. So you can't stop there, but that would be the first thing to do, because, you know, the brainwave patterns are so important.
Yeah. And I echo that. So I think, you know, an app like SnoreLab, exactly what Mark's saying. So SnoreLab's going to, if it's snoring and you're in denial and you want to figure out how many minutes and how loud was it, you know, we're not in favor of having electronics by the bed for various reasons, but for one night or every so often, to monitor the efficacy of the treatment or to see how many minutes you were snoring during the night, that's a great app. I think like what's happening with certain other diagnostics where people can take their blood sugar, they're taking their blood pressure. I think what's going to happen, what I'd like to see happen, and by the way, during COVID, about 6 weeks ago, someone asked New York State, the ADSM asked New York State about whether dentists could deliver on a physician's request home sleep test, and it was no, 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 no. So just at the time where we think we should be improving access to care, it's like what's happening in our government. It's the time where, we don't get into immigration and things. It's the time where certain states and certain governments, certain boards are now saying, no, we're going to limit access to care. So I'm a big, big advocate for a patient being able to get their own diagnostics. They'll be read by a physician. I'm great with that. But I want patients to know how important it is to be able to order. And if you go online, watch Pat One, there are certain companies where they will send it to a board certified. You'll have a telemedicine visit. It's even set up through insurance. Yep. And a patient doesn't have to go through an MD or through a dentist, although that's great because like a lot of people said, if you're a thin woman, first of all, it comes back, we can't help you. You're not a candidate for CPAP. So whereas I do love working with physicians, but I also love the increased access to care and the easiness to deliver a home sleep test. There's no obstacles in the way. They go home with it. They walk out of my office with a home sleep test, FedEx label, or even now it's better because the iCloud's going to bring it back in.
That's awesome. I'm going to be respectful of your time because I definitely want to share a lot of the resources you guys have talked about, and we'll set up a page for that. But I got to ask you one question that's come up over and over in the clinic and on my blog as well, is those darn 3 a.m. wakings where people are getting up around 3 or so. I always get that question all the time, and I just wanted to get each of your perspectives, and I'll start with you this time, Dr. G. Do you have any common, I'm assuming breathing can play a role with that, but have you guys had any unique experience with sort of how to approach those 3 a.m. wakings, which I come across so much?
I think it's a good time now to talk about sleep hygiene. And, I think, you want that room to be cool. So if I'm feeling hot, I got to take the blankets off. You're sleeping with the partner that is going through perimenopause. She's got her night. She keeps whipping the covers on and off. So a dark room. I was on a call with an Alzheimer's group. One man is wearing a mask, an eye mask, and he said that made all the difference in terms of circadian rhythms, like you're saying, Mark. Just putting that eye mask on allowed him not to wake up at 3 a.m., allowed him to sleep through the night just because and even ears. So environmental noise is a big one. And we know that exercise, and I'm a big advocate for exercise, you can't overestimate. If an hour of exercise will improve that and allow you to get through that 3 a.m. awakening. Exercise, it cuts dementia by 50%, according to someone like Perlmutter. So exercise can do that, sleep hygiene, nice blankets, maybe even a weighted blanket in a very cool room, 68 degrees. So no dogs or cats, no one's going to crawl, nothing that's going to, a bed partner who snores, the guy's in denial or the woman's in denial, either you're going to treat it or get into a separate bedroom. The kids are out of the house. You got 2 or 3 bedrooms to choose from. And that might be the difference between, conquering your glucose levels or not conquering it. But if you have a bed partner that's buzzsawing like at 50 decibels, how do you expect that you're not going to wake up at 3 a.m.? And then maybe less water. Everyone wants to be hydrated. This angiotensin, and we can talk about ACE2, and it's all kind of very interesting, but maybe not drink all day, but don't drink water after a certain amount of time. And certainly alcohol will dehydrate you. You're going to wake up at 3 a.m. all the time. You'll fall asleep in a drunken stupor, and then you're up at 3 a.m. dehydrated, and you got to drink water, and that won't happen if you limit the alcohol and drink earlier in the day. I shouldn't say it like that.
Those are actually really key points. I love that. I was actually told that Costco's selling more alcohol now than during the holidays, so I think people are really loading up on the alcohol now. So, Dr. V, do you have anything to add to that?
Yeah, absolutely. All that is correct. I wear one of those masks. It's huge. I used to make fun of people that used to wear those masks or wear those masks. But my 3 things, as I was hearing Michael talk, my 3 things are GERD, blood glucose levels, and alcohol. Those are the things that will wake you up at 3 a.m. other than the obvious, like a cat or sleep partner, a truck driving by. There's a study that says that people that live in a very, like New York, or it was basically out of Atlanta, the study, and it depends on the neighborhood you live in. The poorer the neighborhood, the more likely you will not get a good night sleep. You'll have an interruption. So, but anyway, so alcohol, Michael mentioned that, obviously, I mean, it conks you out, you go right to sleep, but it has altering effects on brain physiology, and it will wake you up at 3 a.m. And then GERD. So, you know, if you have apneas, GERD can wake you up. In a nutshell, apneas fool the body into thinking, because of that pressure, the thoracic pressure from the apnea, it fools the body into thinking that it needs to it needs to lower blood pressure and dump some blood volume. And so, of course, the aldosterone and vasopressin and all that, the kidneys, I mean, they're helping you fill up your bladder because you're not sleeping well. You're tossing and turning, and those apneas are causing that. So that'll wake you up. Obviously, a full bladder will bring you right out of deep sleep. And then you get up, you may turn on a light, which is a mistake. And then, you know, then it's tough to get back to sleep. And then, so alcohol, the GERD is, you know, literally, if you have apneas, it's like a pump, a reverse pump. You're pumping stomach acids right up into your mouth, your eustachian canals, into your nasal passages. It's amazing how quickly that can happen, because you're lying down. And then, of course, you know, you're going to get esophageal cancer if that goes on too long, but that'll wake you up. That's a lot of my patients have, you know, because I ask them, I say, you know, what actually wakes you up? And we talk about it. Is it a taste in your mouth? Is it dryness of the mouth? Is the mouth open? And a lot of them will say, you know, my teeth are really sensitive when I breathe, and I've got this burning kind of weird taste in my mouth. Sometimes they'll express it as being, it tastes like I vomited a little bit. I mean, yeah, you want to, those are all root causes of why someone wakes up at 3 a.m. I mean, it could be 4 a.m. if you go to bed late, but assuming regular schedule, there are a lot of things that can wake you up.
You know, I'd add to that the glucose thing is a big thing that I see in my practice, and it can be either extreme. So some of my patients on very low carb or ketogenic diets are going to bed in a sort of hypoglycemic state, and they can have a major drop around 3 a.m. or even a major spike at that time. And abrupt fluctuations in glucose can really get us out of deep phase sleep. The other extreme is true too. A lot of us that are baking like crazy during this pandemic, and we're snacking on muffins and cake at nighttime, those insulin and glucose excursions can really set a signal to the adrenal glands and make you come out at 3 a.m. So some people actually have to starch up a little bit. Other people probably need to starch back a little bit. But also, you both mentioned intermittent fasting. We don't want to be digesting a huge heavy meal during the night. So finishing that meal between 6 or 7 p.m. can be really helpful for kind of curbing those in my experience. But I think this is a great list that we came up together. So I love everything people brought up here.
Wearing a CGM is a great idea. If you're getting up in the middle of the night, you should get a CGM prescription from your physician, because not sleeping well, it triples your fasting glucose. It decreases your insulin sensitivity by like 30–40%. I mean, that's big. It's all tied into sleep. And then, you know, what is it that's waking you up? Is it poor sleep? But it could be the fact that your insulin, yeah, I mean, it's all tied in together, but low sugar or high sugar can wake you up, but poor sleep, of course, aggravates that whole thing.
Yeah. You know, battle is getting docs to order CGMs as well, too. So I did a detailed blog post on how to get your doctor to order a CGM. So I'm going to put down your guys' resources and my resources on some of the things we talked about, so we can have that info. But yeah, would love, Dr. B, since I got you here, can you maybe highlight some of your key resources? You brought up a lot of great information, but where can people find you? How can they reach out to you? What are some of the resources you'd want to highlight based on our discussion today?
Yeah, I mean, we've got the Facebook page, the Instagram account, we've got the website. But I would, if you're concerned about sleep, I would just type in my last name and Gelb as well into Amazon and read the books. I mean, I think the dental perspective on sleep apnea is very unique, and it's very interesting, and I think it's very approachable by patients. I think dentists are.
I want to actually call it revolutionary. I'm going to interrupt you. I really think it's a revolutionary what you guys are doing. Honestly, as a doctor, I'm saying that we don't have that perspective. So, sorry, keep going.
And then one other thing, just go to our website, askthedentist.com. You'll see lots of stuff on sleep and intermittent fasting and how that's good for reversing cavities and all that stuff.
I love that site. Absolutely. Dr. G.
Yeah, so we started the Foundation for Airway Health. It's a good site. It's for the public. It'll be a lot of information about sleep and airway. And then if you want to find a practitioner, we have a group of MDs, physicians, dentists, myofunctional therapists called the AAPMD, the American Academy of Physiological Medicine and Dentistry. You can find a provider there in any part of the country, and you can join. If you believe in the airway and you're an airway advocate, it's free to sign up if you're a professional doing this kind of work. So you guys should be on there too. And it doesn't cost anything. And again, it's so we can all have an equal seat at the table. There's a lot of good information on that site as well. And then, you know, like you said, my book also, GASP, is on Amazon. It's a good place to start. And then our websites, you know, Mark's website and my website, Gelb Center, or Dr. Michael Gelb, even better, with all the blogs on it, has some useful information. Yeah, I think that's a good place to start.
Fantastic. And for my resources, you can go to culturalhealthsolutions.com. That's where I blog. I'm also at Instagram at RonishSinha, so check out my resources there. But this has been awesome. I learned a ton here, and hopefully this is going to help support everyone's sleep inside the pandemic and beyond the pandemic too, because this is something we need to prioritize in every stage of our life. So thanks everyone for listening. All right, guys. I think that's a wrap. You guys are awesome. That was fantastic. Thanks so much for your time.
Thanks
again.
Yeah,
we should
enjoyed it.
Yeah, hope you guys stay safe and healthy during this time.
Okay.
All right, take care, guys.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.